Good evening, everyone, and welcome to our April CPARF in Conversation event. Tonight, we'll cover a topic that affects 13.5 million people with cerebral palsy worldwide. I'm Jocelyn Cohen, and I'm the Vice President of Education with Cerebral Palsy Alliance Research Foundation, or CPARF for short. This event is closed caption enabled, and I've turned on transcription. It's also being recorded, and we'll post it on our YouTube channel soon. For additional accessibility, I'll share a visual description of myself. I'm a white woman with dark brown shoulder-length hair that's down and brown eyes. I'm wearing large teal glasses and a dark green sweater. There's a CPARF-related background behind me that has white and different hues of green. Sometimes I may look like my eyes are looking away from the screen or rolling, but that's part of my cerebral palsy. In case this is your first online event with us, I'd like to tell you a bit about what CPARF does. Despite being the world's most common lifelong physical disability and affecting 18 million people worldwide, cerebral palsy is one of the most underfunded conditions. That's why CPARF funds research and technology that will positively change what it's like to live with cerebral palsy. On the innovation front, we run Remarkable US, the US-based disability tech startup accelerator that's part of the Global Remarkable Accelerator program. And through seed funding, mentorships, deep dives, and support, we help startups bring affordable, life-changing technology one step closer to people with disabilities who need it. Because the world isn't built for disabled people, but thankfully, there are companies that place disability at the forefront, and Remarkable US is working with them. They're built to fill in gaps, meet crucial needs, and make accessibility accessible and affordable. On the scientific side, we're currently funding an array of projects that address cerebral palsy at all ages and stages of life. CPARF-funded research projects and fellowships focus on technology, regenerative medicine, genomics, adulthood, early detection and early intervention, and chronic pain. The discoveries that researchers make today will make a difference for millions of people with cerebral palsy soon and for generations to come. And tonight's guests, Dr. Amy Bales and Dr. Mary Gannotti, have prioritized studying pain management for adults with cerebral palsy so that people can receive more effective treatments and live more comfortably as often as possible. Amy is a physical therapist at Cincinnati Children's and an associate professor in the College of Allied Health Science at the University of Cincinnati. She earned her BS in physical therapy from Indiana University, her MS in pediatric physical therapy science from Boston University, and her PhD in clinical epidemiology from the University of Cincinnati. Mary is a physical therapist and professor of physical therapy at the University of Hartford. She earned her BS in physical therapy, her MA in applied anthropology and public health, and PhD in medical anthropology from the University of Connecticut, and additional training in epidemiology and disability studies at Yale University. This is a hot topic in the CP community, and I am excited to have this conversation. Please leave any questions you have in the Q&A box, and we'll get to as many as we can in the second half of our time together. Welcome, Amy and Mary.
Thank you.
Thank you. We're so glad to be here. It's a great opportunity.
I'm so glad to have you. So to start things off, Amy and then Mary, can you each tell us a bit more about yourself and your professional backgrounds?
Sure. Hi, I'm Amy Bales, as Jocelyn said. I've been a pediatric physical therapist for about 39 years now. I've only worked at large pediatric hospitals in big urban areas. And like Jocelyn said, my original degree was a bachelor's in physical therapy, so I have been a clinician all those years. But more recently, I went back to school to get my PhD so I could be more involved in research. Along the way, I also completed some training in quality improvement methods, which is what we're going to discuss today with the projects that we're working on. And quality improvement is a little different than what you think of as research in that we're studying the process as things go on, and we're constantly learning and changing things to make the process better. So this isn't like a typical research study where we're going to enroll people, collect some data, and not look at the data until the end of the study and then learn from it. We're going to be learning as we go along. So that's why I'm excited about this project and my role in the project.
Mary?
Great. Well, I'm a pediatric physical therapist and adult neurophysical therapist, and I've been a physical therapist, same as Amy, about 39 years. And I started working with adults with cerebral palsy actually in middle school because I grew up next to an institution. And similar to Amy, I've only worked in large children's hospital and urban centers or in institutions. My first job was deinstitutionalizing 400 children and young adults in Oklahoma. I've also worked internationally, and I've always worked with an eye to what happens when you grow up. And I started doing long-term follow-up studies with adults with CP with the Shriners Hospital in the early 2000s, really about 2002, 2003. I'm really excited about the Cerebral Palsy Research Network and the support we have from CPARF. And I'm excited that we have adults with CP and their issues at the forefront.
Thank you so much, Mary and Amy, for sharing a bit of your backgrounds. And Mary, you sort of answered my next question, which is amazing. I love when that happens, as to what inspired you to work with adults with CP. Amy, what inspired you to make the shift from pediatrics, and how has that shaped the research that you do?
Yeah, great question. So I think there's two things that led me down this path to working with adults. The first one is, having worked with children for all these years, they've stayed with our centers and continue to come back for care. So we found ourselves treating and seeing adults in our clinics and such. So I've watched people grow up and see them experience life as an adult with CP. And then the second thing that happened that really inspired or created the shift was the Cerebral Palsy Research Network, like Mary discussed. So I've been part of the CPRN since it started in around 2015. And when we did one of our first meetings, we involved everybody to come up with a research agenda. And there were people that live with CP, caregivers, clinicians, researchers, everybody was there. And one of the top priorities was adults and adults having pain. So I started to learn more about how adults were experiencing adulthood, and it didn't sound very good. So because it's a priority for CPRN, I got involved in one of the quality improvement projects that I lead for the network for CPRN. And that's really been guiding us down this path. And that is exactly how it's shaping the research that I'm involved in. I provide the quality improvement expertise. Mary provides the background in adults with pain. I'm learning all that stuff, and there's just a great synergy between all the people involved.
Yeah, and we'll get into more details about CPRN in just a little bit. They are a strategic partner of CPARF's, and we love working with them, and we're so glad that this study is a partnership between our two organizations. Mary, did you want to add anything about how you kind of took your personal experience as a clinician and all this deinstitutionalizing experience, which I imagine provided a window into a world that most people do not see, and how that has shaped the way that you approach research, whether it's this project or others?
So I always like to think about the cost benefit and what we're doing and if it really makes a difference in the end. Because having worked as an, in my training in anthropology in other countries in low resource areas, you need to really think about ethically, what is it that's really the most important for this family, for this child, for this young adult, and then that's going to make a difference in their life. And having worked at these wonderful hospitals, having seen both ends, and then you come to that there's a middle ground. There's still a person there that may or may not have felt like the treatment they got was the most beneficial. And as a PT, I say, what can I do now? And as a physical therapist, the things that we do best are exercise, and the problems that adults with CP face with pain, in part could be alleviated by some of our interventions. So that really guides, how can I make a difference, or how can physical therapy make a difference now in prevention and in current treatments?
Thank you for sharing that additional background, and you just spurred me to think of another question, which is that one of the challenges that I sometimes face and that I know my fellow adult friends with CP face is that sometimes physical activity can cause more pain. Have you kind of landed on a sweet spot or a balance? Is it different depending on the age of the person, the kind of CP they have, the different conditions that they have in addition to CP? Like what's the magic in finding the sweet spot if there is one?
Well, that's why you need an individualized exercise program, and you need people. One of the roles of the PT, I think, is to empower each individual, whether they have CP or not, to get to know their body and find out what works for them.
Mhm.
And not all of the answer for pain management is exercise. Certainly, exercise can help on the prevention end quite a bit, but some people are at a point where that is not the answer. But physical therapy offers other modalities, biophysical agents, and combined with mindfulness, I can think that's really effective. So really the sweet spot is the individual being empowered to know their body, to know what works for them.
Thank you for that insight. Amy, do you have additional things to add?
I think what I would say is that, no one thing is going to work for everyone. It's probably going to be a combination of things. But for example, if walking hurts, try getting in the water. If, I think there's so many different things we can do that we hope we can find something that feels good, combined with other things as well. So I think, we don't exactly know all the answers either. We think that exercise and physical activity has a key role. And that's a good segue into, our next things, what we want to do. We need to find out what works best. So
Absolutely.
Yeah, and we do know that adults with CP experience so many things so differently than the typical population. But I see that Dr. Debbie Thorpe is one of the participants, but adults with CP don't even receive the minimum care that their typical peers do, even when it comes to low back pain and physical therapy visits. Dr. Thorpe and I did analysis of some data sets where we could show that when we match people with the same type of diagnosis for musculoskeletal issues, those with CP were less likely to get PT and then have less visits.
There's so many factors that lead into that. That could be a whole other webinar. And if people have questions related to that, please do add them in the Q&A. But these are all really good insights. And I just want to keep us moving on the pain side of things, but that definitely intersects with physical therapy, physical activity, and lack of access to medical care, or feeling like you have lack of access to medical care. So the study that you're co-leading with each other is focused on screening and classifying pain in adults with CP. Amy, starting with you, can you explain why these are such important aspects of the pain management process, especially in the context of high pain prevalence for adults with CP?
Sure. Yeah, that's a great question. So, some studies report that as many as 70% of adults with CP have pain. So there's a lot of people that are hurting, but you guys probably know that already. The reason this is so important to screen and classify pain is because there's different types of pain. So there's basically 3 different types of pain. The first type is when there's damage to the sensory nerve tissue. Another type is when there's different damage to other tissues, sometimes like musculoskeletal tissues. And then another type is when there's no damage to any tissue, but your body has an increased perception of pain. So those are the 3 types. And sometimes people have a mixed type, like more than one of those kinds. And the treatment for each of those is different. So that's why it's really important to classify the pain appropriately. So we know the next step would be to treat it, right? So we're trying to get closer and closer to treating pain effectively. And that's why it's important in the process and in the context of the high pain prevalence in adults. Those types of pain have fancy names that all sound alike. If you're interested, we can type them in the chat.
They do. That's why I confuse them when I see them written out. They
Me
sound
too, but I'm getting better and Mary's taught me. So yeah.
Mary, do
Yeah.
you want to add anything to that?
Well, I think that something that's really exciting about this study is that it's happening right in the clinic. And we're tasking clinicians that at each visit, every time you see an adult with CP, the clinician is going to ask about pain that interferes with function. And we've already demonstrated that, with 4 hospitals, and that we can do that. But now in terms of classifying that, that is going to identify a problem that we know is a big problem that before the QI study was not consistently asked. It was under 50%, and now we're over 80%, 90% of the visits, clinicians are asking this question. And then it's going to give a little nugget of information about typology to help when the referral goes out to a pain clinic or a physical therapist or whatever the local plan will be, because each hospital might vary. So I'm very excited about it because it should have an immediate impact on those that are receiving care at the hospital.
Absolutely. Is there a dimension or mechanism that is asking, in addition to the pain interfering in everyday activities, if it is like more, less, or the same as it has been? Is there a measure of like change over time, or is it just at this, at this juncture in time?
Great question. At the current moment, it's at a single visit and the clinician's just asking if they have pain that's limiting function. We're not asking if it's changed over time. Now, ideally, these people would come back to their visit clinic, and over time, we would be able to track that. So we know that there's a lot of nuance to understanding pain and how people experience pain. We also know that it's really hard to change processes in the clinic setting. So we're building on our successes.
That makes sense.
Yes.
You're really creating a foundation that will be useful and that will be easily adaptable. And the adoption is the big part of the whole thing, because if people adapt.
Well, the way Amy has trained us is that you do one thing at a time. And first, we're just trying to find out if people have pain that interferes with function. And we've accomplished that. And now we want to spread it, and we went to other hospitals. And now we want to ask more about what it feels like. And it might, in that what it feels like question is to be determined.
Sure.
We're discussing that as a consensus group with adults with CP that have pain and providers, and very well the pain intensity question might be part of that.
Thank you. This is all so fascinating to me as an adult with CP who does experience pain. So CPARF, as we've mentioned already, we have this strategic partnership with the CP Research Network, and that's comprised of more than 30 institutions focusing on CP treatment and management. And we talked about how this study is aiming to standardize pain screening and classification across several institutions. So Mary, can you further explain the significance of this within your study?
So the important thing is we change practice and that it actually occurs. And as Amy probably can elucidate much better than I can, because this is her area of expertise, that once we start the process and we develop a way to do it, and because the CPRN network works with the EPIC electronic medical record, and we can add things to the medical record, once it's established within these 4 centers, it could be transferred to other sites. You want to add to that, Amy?
I think, I think you've said it very clearly. I think the significance is that institutions that are involved in the network are very committed to collaborating and improving things. So having the network and having these institutions that are willing to, once we figure out what works, well, first of all, within the 4 centers, those are the 4 centers that we're going to be testing this with. in quality improvement methods, the purpose is to test some processes to see what works and doesn't work, because we might have to adapt them. We might just adopt them if they're really good. And the third way is we might abandon something completely if it didn't work. So we're testing it in a few with the goal of spreading it throughout the network. So I think that's a key, this offers us a framework or a structure to be able to do that.
That's fantastic. The more institutions that can implement things that help people with CP, the better off we all are. Rising tide lifts all boats and everything like that.
Oh, yeah.
Debbie Thorpe has an excellent question in the Q&A, so I want to ask that, which is, should you recommend that consumers share their pain experiences with clinicians, even if they think their pain is insignificant?
You're getting ahead of us. I have that written down. Absolutely. You need to be an advocate. You need to speak up for yourself. You don't need to live in pain. You need to ask for what you think might help. Absolutely.
And I think that the baseline for most people with CP is pain. And then there's the pain that you have, and then there's the pain that interferes with function.
Mhm.
And so even if you don't have pain that interferes with function, you should be mindful that you do have pain and seek ways to try and take care of it, protect your joints and so forth, because we do know that with aging and with a skeleton that might not be as strong in terms of bone mineral density, you're at much higher risk with aging for that pain to increase and interfere.
I just want to echo Mary's point that even if you have a baseline of pain, you might not even realize that it's pain. You might just register it as how you feel daily. And so it might also require a little bit of introspection and stepping back from yourself, which I know can be really hard to say, you know what, this actually hurts, but because I'm coping with it all the time, I sort of block it out. And the way that I talk about my CP sometimes is that I can turn the volume down. Like the volume is low, so I hear it humming in the background, and then every now and then, like someone just turned the knob up, so it's blasting in my ears. Whether that's like a functional thing or a pain thing, that's the way that I experience it. So it does require just thinking a little bit more about what it's like to be in your body, which some people with CP are really accustomed to, and others might not be.
And just if I could add really quick, Jocelyn, when you
Sure.
talked about introspection, I find that people with cerebral palsy have such a striver mentality, but I can do the stairs. And, I don't have CP, but I'm a older woman, I'm a human being. And I was at yoga, and the yoga teacher said, just because you can do something doesn't mean you should do something.
Mhm.
So I would ask you to think about that in your daily life. Are there things that you can do that maybe you shouldn't really do? I mean, maybe you should think about swimming for exercise instead of, do you have to do those stairs or walk, to it? So just be mindful.
Yeah. Just because you brought up stairs and how that can be a little bit taxing on the leg joints. If you're someone with CP whose arms are not affected by your CP, arm bikes exist. They're more rare, but you can find them in a PT clinic, and it's a good way to get some cardiovascular exercise if you feel like you can't ever get your legs to move comfortably or fast enough to get your heart rate up. Just a side note, I do love the arm bike. It is really hard. So
Some
most of the
gyms have
questions-
them too. A lot of gyms are having them too now. So ask.
Yeah, gyms are a little bit fraught for people with CP. That's why I started in the PT clinic. But I know some folks I know that have been to PT and have gone to gyms and wanted the arm bikes, haven't had them, so they're a little bit more rare. I wish they were less rare. Because I would maybe it just depends on where you are.
Yeah.
Yeah.
What type of
So
place?
we have an
Yeah.
prosthetist in the Q&A box who said that he happens to work with quite a number of CP patients, but he never saw the referring PTs checking them for pain. And is there a system you use to check for the degree of pain? And I find this so interesting coming from someone who is like creating orthotics, which were, as a child, one of my main sources of CP related pain. So Amy or Mary, whichever one of you wants to take this first, go for it.
I'll let Mary go.
Okay.
So adults with CP oftentimes don't, they have various providers that they see. I would imagine that it's standard protocol for everybody to ask about pain, especially in the PT realm. And that's very unfortunate, but there can be a high degree of variability. I mostly refer the adults with CP to outpatient rehabilitation centers that see people with spinal cord injury and stroke and head injury. So they have some neurological background. But certainly what you're saying is that there needs to be education more broadly among physical therapists to address the need of adults with cerebral palsy in the general community clinic. And tonight at 8 o'clock, we have a community of practice to try and build that. And that is a really big need that physical therapists see someone with CP. They're like, I'm not a pediatric therapist. Yeah, but you're still a physical therapist. And yeah, so the awareness needs to grow. Thank you for bringing that to our attention.
And perhaps, off another an email or something, you can email us and we could give you some suggestions for what you might consider using in your orthotic and prosthetics visits to at least see if they're having pain, and you certainly don't want to make it worse with any braces, or are they coming to you for braces and that's you're hoping to alleviate some of their pain. It certainly should be something you're looking at based on the experience. Like Jocelyn said, that braces were a primary cause of her pain as a child. So
that said, I know there's been a lot of advances in the last few decades, so I'd hope they're slightly less painful. Mary, you were going to say something.
Well, it was interesting that at our annual meeting last week, one of the orthopedic surgeons said to me, it's funny that you keep talking about back pain, Mary, because all the pain I see is in the toes and the feet. And, so I would imagine that there are some foot pain it can be a huge issue for adults with cerebral palsy. So kudos to the orthotists that try and make that more comfortable.
Absolutely. So someone asked this question, moving away from musculoskeletal pain to sensory pain, what are the causes and what can we do to help? Do you have any answer?
Yeah,
magic answer for that? You look like you might.
I have an answer. So interesting. So, when you're talking about the centralized pain, the pain when there's nothing there, but you still have pain, the origin of that is not 100%. The thought is that when somebody is just in pain, then you just get your brain just registers that, when they have a functional MRI, we just see all this pain stuff. There is a researcher at Johns Hopkins, Dr. Eric Shin, that said to me, he's looking at people's MRIs because he's thinking it might be related to some sort of thalamic pain or some sort of pain that's from damage to the sensory cortex that is then perceived in that way. So the origin is not known as of yet. The mechanism, there's multiple. Some people thought it might come from sort of like PTSD, where you're in the NICU and then you're this and then you're stretched and then you're cut and then you're that and then blah, and you just develop these pain pathways. All of those are probably true, and it probably vary on the individual. But the treatment for central sensitization of pain is not 100% clear, even in people without CP and low back pain or knee pain. The number one way to deal with it is really mindfulness, is just sort of meditation and movement. and really trying to be reflective, thinking about gratitude, being present. Opioids are not seen to work. There are some neuralgic types of medications like gabapentin that might be given. CBD is also a treatment, CBD with THC as well. And then for some people, exercise provides an analgesic effect. It definitely does a little bit for people with low back pain without CP, but those are some of the studies that we need to start doing to be more specifically. But again, everybody's brain is different and they experience their CP different. So it might be a combination of things that would have to be addressed.
Thank you, Mary. So moving back to the study itself, what does success look like to you with this project? Starting with Amy on this one.
Well, I think, as we described, we're already screening for pain that interferes with function, and we now want to classify it across these centers while we're asking.
Right.
So I think success, there's going to be, ultimately we want to be successful. We want to get something that we all agree on we could do in the clinics. And we want to successfully do it with all the adults that come to see their providers. But along the way, some key points of success are going to be that we try different things. We learn from them. So even when it doesn't work, that's a successful thing because then we adapt it to make it something that does work. So I think, success is going to look like everybody coming together and coming to some kind of agreement or consensus, Mary has said, about how we might implement and what we might ask and do in the clinic, realizing that we can't do everything. What can we do? And sometimes it's very hard just to get everyone to agree on something, right? We all know that. So I think that success is going to be moving through the process, hearing each other and listening to each other, and then learning from what we're doing to where we are at a point of actually doing it. I don't know.
Thank you.
That answers the question.
Yeah. And that at the centers, they're able to actually do it. And then we're able to say to people, these are the questions we asked. And
Here's the
they were,
package. Mhm.
here's the package. And you can upload it into your electronic medical record or adopt these questions. And then the next step would be, we're also hoping that, we'll get this large number of adults with CP where we'll able to then describe, in these 500 people that we know that we validly screened and classified pain the way that said we were going to do it, what is the distribution look of the different types of pains, and can we find any sort of relationship with their GMFCS level or any other attributes so that we might start to then, develop ideas for treatments, because not one treatment's going to fit everybody. So we're going to have to sort of classify people and then think, okay, for this group of people, what treatments would we then try out and see if they're effective?
I just want to add, for anyone who doesn't know, GMFCS is the gross
Thank you.
motor function classification system. Everyone might know that. There might be some people that don't, so I just want to throw that in there. And it's basically about the ways you move through the world and whether or not you need to lean on things to do so or use wheelchairs to do so, and how much assistance you need when you're moving throughout your day. That is an oversimplified version of it, and there are 5 levels of GMFCS. One is your CP is the least involved, and I've seen folks with GMFCS 1 run marathons, and then you have the spectrum between 1 and 5, and 5 is, I believe, that someone needs help with all activities of daily living, and they are in a wheelchair most, if not all of the time. I see that someone raised their hand, but if you could put your question in the Q&A, that would be the best, and then we can answer as we're able. While we wait for that wonderful attendee to type their question in, starting with Amy, what do you want adults with CP to know about your work in pain management and how this can impact them down the line?
Well, I think we addressed this. I think that what I'd like you to know is that we hope that you feel empowered to speak up and advocate for yourself. You don't need to be in pain, all the things Mary talked about and
Mhm.
Jocelyn, being introspective, and start asking your providers about these things, ask for referrals for physical therapy, ask to try different things. So that's what I'd like you to know about it.
Thanks, Amy.
And by you doing that, you're actually teaching the providers and moving things forward.
Yes. Asking for bone mineral density scans, asking for MRIs of your spine if you have low
Good one.
back pain,
Good one.
you
Your
know,
neck also.
your neck and your spine. Ask for MRIs, ask for bone mineral density. And then once the PT has that, it will give them knowledge and power to employ a lot of different variety of techniques.
Mhm.
But you need to rule out, you need to sort of make sure they do the appropriate tests, and you might have to fire doctors.
Exactly. Don't feel bad. If
Mhm.
you might need to, I was going to say audition.
Audition.
Two different sides of the
At the
same
end of
thing.
the day, you might need to audition several doctors and interview. Yeah, it's part of the process.
Yeah.
Yeah, be an aggressive consumer and know that there are options out there. And one thing I do want to put a plug in for is sleep and hydration.
Good one.
Yeah, so there's such a really interrelationship between sleep and pain. Um, and so these sorts of things need to be sorted out, and you might need to get a sleep study.
Mhm. That's
And
really
they're doing,
interesting to think about.
yeah, I mean, that's important. They're finding it's related to obesity and it's related to pain, in so much that a sleep study is indicated in either case.
One thing I'll tack on to what you said about being an aggressive consumer is that, I know that I'm coming from a place of privilege where I can speak up, do it loudly, do it often, have tactful conversations that are sort of arguments, but not really, with the people that I need to have them with. But I know that not everyone has the ability to do that. So if you have a trusted person in your life who can use their energy to do that for you or be with you, to facilitate those conversations. That's another way to increase the quality of your care.
So nice.
Yeah. You've covered some of this because we've had such a great conversation so far, but is there anything else, starting with Mary, that you'd like other clinicians to know about your research and your approach?
I think that one of the things that I want everyone to know is about prevention. A strong skeleton, heart, muscles, and character is built in childhood. And I understand that some people can't move that well, and that people have a lot of illnesses and so forth. But trying to be as active and healthy as possible in childhood is very helpful. But then do not be dismayed. We know that bones and muscles and hearts are plastic. And although bones may take 6 months, muscles only take 8 weeks. You're never too old to call on to the plasticity of your body. And then meditation actually grows part of your brain, your amygdala, and other areas in your old brain that help with self-regulation. And I don't know, but I know I have a lot of anxiety, and it's just getting worse as I get older. And I can imagine that having a chronic condition with lots of barriers and frustrations every day might be very triggering for people. So I think trying to use appropriately dosed exercise during the right stage of life, believing in plasticity and neuroplasticity, bone and muscle, is sort of my approach.
Thank you, Mary. Amy, did you have anything to add?
I think there's a lot of great questions in the chat. So I have very little to add. The only thing I would add is for other clinicians to know, start if you're working at centers, they don't have to be big hospitals like we work at, but start asking other people and other people that take care of these people to do something. You can make changes, even if they're small, towards, getting at this issue, evaluating people, asking about their pain, trying to address it. This is within our realm.
Yes, thank you. And you're right, we have a ton of great questions in the chat, so I'm going to shift there for a bit. I see Mary is answering one of them, so I'll go to the next one. So we have Eric, who is an adult with hemiplegic CP, special education teacher, 52 years old, and he wants to know what the experience of adults with pain might look like, or how adults can find CP medical practitioners. I know a lot of that is based on where you live, but if either of you have more insight, please feel free to share.
Well, both the American Academy of Cerebral Palsy and the APTA have provider finders. And you can put your specialty in. But in terms of what the experience of an adult with CP might look like with pain, I know it's also CP who have no pain. With hemiplegia, you have asymmetry, and yes, you might have, and you have a higher risk for having pain with asymmetry. I know one of my good friends is 83 years old, and she's got pretty significant hemiplegia and no pain. So is this to find that? Okay, so I would say it's very variable, but you're probably at high risk if you have a leg length discrepancy and an asymmetrical gait.
I think the other thing I'd add to that is, start calling around, check with the, Mary mentioned the American Academy of Cerebral Palsy and Developmental Medicine, that's AACPDM, and then the American Physical Therapy Association, APTA. This is where she said you can inquire with them about providers that see adults with disabilities.
Sorry.
As well as, calling around local hospitals, asking people, looking up providers in the area, maybe call a hospital that's a bigger hospital if you live in a smaller town. I think it's like detective work, right?
Yeah.
What I do is I usually, and I'm happy, hopefully Jocelyn will share my email. I'm happy to do email triage and give people articles that are related to whatever they need. And then I say, just march into the whatever stroke center, brain injury center. Every state usually has one really good rehab center. March in there and give them this article and they'll know what to do with you. So that's another strategy.
Yeah, I will make sure that I send Mary's contact information around to everyone who's attended. I want to throw something in there that's unorthodox and not ideal, but it's something. One other thing is there are regular CP clinics out there that might be near you. If you don't feel like doing the extra search on the APTA site, asking around to the heads of those companies to see if they might have people who could meet your needs, whether or not they've treated people with CP before. A lot of physical therapists, most that I've met, are lifelong learners. And if you're at a point in your life where you're comfortable sharing your story and you're not burned out, as sort of Morgan has brought up in her question that Mary's answering, then if you're willing to sort of have a real two-way conversation with a physical therapist who doesn't have as much experience with CP, you could still get a lot out of that, whether they're an orthopedic physical therapist or a neurological physical therapist, or if you see one of both. And yes, I just want to state, because Morgan's question is, what about client burnout? As clinicians, what advice do you have for the lifespan? Because this is a forever type of thing. And how do you balance your program for your health and for your life? And I will say that at this point in my life, I am a little burnt out. And I have access to a lot of information, and I'm a person who's through webinars like this and other means getting the information out to the community, but I would be lying if I said I wasn't burnt out. So the more you can, and it takes time, which kind of leads to a little bit more burnout, but the more you can find people who are medical allies for you, like Mary and Amy, who will listen to you and try to understand what you're going through, they're then also connected to a network, like actually through the CP Research Network, but also other folks that they know that they may be able to connect you with. So it might be a lot of work for that first part of the journey. And then once you find a good person who knows a lot, a little bit less work gets taken off your shoulders and put onto shoulders in front of you. It really is an allyship, and I appreciate the people like Amy and Mary who treat it as such, because it makes it a lot easier on the harder days with CP. So Mary is just a question answering machine over there, but I see Debbie asked about suggestions for people on Medicaid where doctors are reluctant to refer for MRI or DEXA. Those are some of the tests that you both were referring to as reference points to help people work on their pain. And yeah, insurance and private insurance and Medicaid are elephants in the room and extra barriers that we wish weren't there when it comes to getting the treatment we need. So do you have insights that you'd like to share about that? If either one of you want to take that, go for it.
I wish Debbie could give us some insights. So I mean, I think that there's justification. There's definitely justification for it. So if they deny it, that you can always appeal it. And although appeals are a pain in the neck, they're well worth it.
Yeah. Pain,
and
pain
I
in
think
the neck
that
for getting rid of pain is a good switch. Amy,
Yeah.
you look like you were gonna say something.
I think, I don't have a good answer for this because there's a lot of things that don't get paid for and we keep needing to appeal. I think the nice thing about CPARF and other organizations is that they're really, there's some advocacy involved and getting involved in those kinds of things may not help you get your own personal DEXA scan, but I think those efforts will help us move in the right direction.
One of the other things I would recommend, sort of going back to the allyship that I was talking about earlier, is finding communities where you can connect with other adults with CP, because they may have tips and tricks. There are also parents and caregivers of people with CP that can provide their insights and have it be sort of a symbiotic relationship between the parents and caregivers of both young children and adult children with CP and more independent adults with CP. Christine made an excellent point about differentiating between CP specific pain and then the role of added comorbidities or conditions and how pain increases with added diagnosis. So in the study that you're working on, it sounds to me though that it's like a very general question necessarily, right? Because you're starting with a foundational question. So it's not saying, what is your CP pain like for the purposes of your study? It is, are you experiencing pain that is interfering with your daily functioning essentially? But
right.
Outside of the purposes of this study, what are your thoughts on saying like, this is my cerebral palsy related pain and this is my other pain? Like if someone's a migraine person or something like that. Amy?
Well, I think two answers to that question. So what Mary explained is we're going to start asking these questions and keeping track of answers. So in doing so, we will have, we hope, 500 people that have answered these questions. We will know other things about those people if they have other comorbidities, so that we can actually look at that like a typical research study where you look back and you look at all 500 people and say who's got what pain and maybe look at by age and other comorbidities. I think that, I don't know that everybody would agree with me, but figuring out what is the pain from your CP and what is the pain from other things, you are one person. So it's really important not to package the pain in those categories, I think, because I don't have CP and I don't package my pain like, well, I tap danced when I was 10. So what's related to my tap dancing and what's related to this?
Right.
So I don't know if that probably doesn't answer your question. I think, yes, we'll be able to look at some comorbidities at the end when we've created this way of gathering information from usual care. Go ahead, Mary.
I totally agree with you, Amy. I mean, it's the whole person. And the reason why we're saying people with CP is because, yes, it's an underserved, ignored, dismissed population. And by the time the pain or the functional decline, people become aware of it, it's almost like it's not that it's too late, but the only interventions are palliative, just symptom management. You're not going to alleviate it. And when we're talking about people with CP, for us as clinicians, that means that we know even if this person walked, they probably have a different type of a bone structure than their peers without CP. They have a different type of a cardiovascular endurance. Their energy cost of movement is going to be different. There's other things that are going to compound and make the lived experience of that pain and the implications of that pain interference very different. It's a much bigger deal for someone with cerebral palsy that uses primarily their upper extremities for their daily activities if they get carpal tunnel than for someone like me.
That's an excellent.
So again, it's like putting a big alert on it to try and get people to start thinking about it and preventing it in this specific population, not saying that the CP causes pain, because is it the spasticity? Is it the lack of muscle bulk? Is it the poor nutrition? Is it this, it's the whole person.
It's so many factors that both play into each other and cause a domino effect on each other. A physical therapist told me 6 years ago something I didn't know because I did not study anatomy, which is that your lower back muscles loop up to your upper back. And because my legs were tight, it was pulling my pelvis, which was pulling my lower back, and that was pulling my neck and pulling my shoulders. So sometimes I had a headache because my legs were tight. And it was just a really good and kind of obnoxious reminder that everything is connected. So that sometimes when I talk about my cerebral palsy, I say, my arms aren't affected by the brain injury that causes my CP, but they're still affected by my CP because they're connected to my legs, which are. So everything is just pulling on everything else. And depending on who you are, what kind of CP you have, what kind of physical activity you've had, and everything, like all of the factors in your life, it will just feel differently within your body. We just have a few minutes left, and I know we've covered a lot here. I have one specific question from someone else I want to make sure that I ask, and it's from a parent of a son who uses an intrathecal baclofen pump, and they're trying to have it removed with the understanding that there may be a risk for pain. Do you have anything you're able to recommend or share with as pain management options to use once he gets the pump removed? Or do you not feel comfortable in this setting?
I have experiences I could share that may or may not be relevant.
Okay.
So what is the individual's type of presentation? Dystonia?
That I don't
hypertonia?
have. This was someone who registered and included that question when they registered.
Yeah. So baclofen pumps are primarily used for spasticity management, and sometimes the spasticity interferes with function, and sometimes it might be that the spasms keep people up at night and cause pain. So if the person, it would really depend. If the person has a baclofen pump for spasticity management, there are other alternatives in forms of rhizotomies. And the neurosurgeon should be consulted, and there should be a tone team that could do that. For baclofen for pain, again, it's usually the pain would be mitigating the spasticity, right, Amy?
Yeah, so I think that depends on why you had the pump, but certainly you're either gonna wanna address it in another way if it's spasticity that's been, causing the pain. That could be through oral medications, or like Mary said, rhizotomy is beginning to become an option for people that maybe don't walk, that in the past they would have not have been offered a rhizotomy, but just to alleviate the spasticity and the pain, that is becoming, more neurosurgeons are beginning to think about that. So I think you just, need to ask your providers, if we remove the pump, what are some other options we might do?
Sure.
Or are they gonna wait till there's pain? Has it been a long time since you've been on the pump and you don't know what the tone is going to look like until it's removed?
Right.
They might have to wait and see a little bit.
It's a really
Yeah.
complicated dance.
But there's surgical and oral medications, and there's also topical medications. Again, in my experience with people that have removed the pump and had a lot of spasms, and they've used creams, whether they be CBD creams and so forth, and then the Valium can be used for the spasticity at night.
Yeah, or they go back on oral baclofen, but you need a much
Or
higher
oral
dose.
baclofen.
So there's several things, you could do Botox, you could do phenol blocks in different places. There's a few ways of addressing it without knowing. It's sort of hard but it's good that you're paying attention now.
Yeah. With just a few minutes left, I just wanted to see, Amy and Mary, if there was sort of one parting thought you wanted to leave people with about the QI research that you're doing, and in general, the work that you're doing for adults with CP and the pain realm.
I really appreciate being able to discuss this with everyone, and I like seeing the questions. I wish there's a way we can have more conversation. So thank you.
Yeah. Yeah, and I'm really excited about the opportunity to be a part of these two great organizations, CPARF and CPRN. And I'm on if I was a consumer to the consumer community, adults with CP, I think that this is a great opportunity for you to get your voices loud, because you have some big organizations that are also out there making noise too, to get your needs met. Just like the autism community and the Down syndrome community. It's your turn now.
Thank you for that so much, Mary. And thank you to everyone for joining us. So please make sure to keep an eye on your inboxes for more about upcoming programs, including our first Disability Tech Talk of the year with Steve Ferreira and Tyler Susko, where we'll discuss innovations that make working out accessible for wheelchair users. Mary, you might want to join in on that conversation too.
I will.
So, follow us on your favorite platforms to learn how we're bringing science and technology to life to change what's possible and make accessibility accessible. Enjoy the rest of your night. Take care, everyone.
Thank you so much.
Thank you so much.